Good afternoon, and welcome to HIT Policy Update with John Halamka, MD, a complimentary webinar from HealthSystemCIO.com, sponsored by OnBase by Hyland. Little housekeeping before we get going today. My name is Anthony Guerra. I'm the Editor-in-Chief of HealthSystemCIO.com, and I will be your moderator today. We suspect you're going to have some questions, and we encourage you to send them in, type them in at any time to the lower right-hand corner, the Q&A box, and send them in, and I'll be holding those, prioritizing them, and posing them later to Dr. Halamka. But you can go ahead and send them in whenever they occur to you. You see the URL on your screen for the deck. There's a shortened URL at the bottom of all slides, and I will also send it out in the chat box during the event. As far as an archive goes, we will have one, usually ready within 2 business days, and you will receive an email when it's ready, and a separate registration is required. So you see how we're going to spend our time today. We're going to hear first from Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. He's going to go 20 to 30 minutes, and then we're going to hear from our sponsor, represented by Lorna Green, Senior Healthcare Informaticist with OnBase by Hyland, and then the Q&A with Dr. Halamka. So without further delay, I'm going to turn it over to our good friend, Dr. Halamka. Dr. Halamka?
Well, thank you very much, Anthony. And as you told me before this presentation, we are competing with the World Cup. So I will do my very best to make this the goal that makes your day. How about that?
Wow, very nice.
Okay, so hot topic this quarter, try to make it a little different every quarter, is Meaningful Use Stage 2 delay. Is it a delay? What does it mean? What should you do? We'll go through some guidance, and I'll describe what Beth Israel Deaconess and its affiliate hospitals are trying to do. There is a 2015 notice of proposed rulemaking for a new set of certification rules, which are entirely voluntary. We'll describe what I think is going to happen there, and where, in some ways, it gives us a signal as to what's going to happen in Stage 3 in 2017 to come. ONC, since we last met, has reorganized and refocused to talk through what that means. And part of it is streamlining their projects. What interoperability areas will they focus on over the next year? What can we expect to see in terms of innovation and new EHR functionality? And I want to spend just a couple of minutes reflecting on the Jason report. The Jasons, if you're not familiar with them, are in an interesting way kind of like Manhattan Project people. I mean, it's nuclear scientists and neurosurgeons who gather together under the auspices of the MITRE Corporation to solve some of the really challenging problems we have in society. And they were asked by AHRQ to develop a vision for interoperability and the EHR of the future. A lot of talk in Washington about what that means, and a lot of hearings will be held looking at how we might incorporate their ideas. So let us begin with Stage 2. So, of course, I have the slide straight from our friends in federal government showing you what the Stage 2 delay is all about. And it really goes something like this in simple terms. 80% of hospitals in America, I think, won't be able to achieve Meaningful Use Stage 2, and it's not for lack of trying. Every CIO I talk to says, I have done everything possible to get in certified software, train my doctors, change the workflows. The problem is the ecosystem around me. It's as if I'm the only guy in town with a fax machine, and I can't send it to anyone. And so this is our challenge. If we're going to have 10% of transitions of care sent electronically from point A to point B, you have to have a sender and a receiver. And the way that the regulation is written, you really have to, in effect, make sure that it got to someone on the other end. And so hence, just sending it out to the ether isn't sufficient. You need that trading partner. There's also some challenge in some organizations of getting adoption of the patient portal and secure messaging. And even if you have a portal and it's adopted for patients to look at their records, they may not be doing secure messaging to the extent that you need to hit that 5% threshold. And an EMR, and making sure that you have full rollout of your electronic medication administration record for some organizations is a challenge. It's very expensive often to buy the hardware that you might need bedside barcode readers, iPhones, iPads, cows. So these are the things that are providing a lot of challenges for CIOs to get this done by September 30th. Remember, the last attestation for 2014 is July 1 through September 30th. So ONC said, okay, we get it. September 30th is too hard, so we will allow you in that attestation period for 2014 to use the Stage 1 meaningful use criteria. You don't have to do the transitions of care. You don't have to do EMAR. You don't have to do the patients using the portal to send secure messages and view, download, transmit their records. So what I see is that all the CIOs in Boston have already installed Stage 2 certified software, are already building up directories of providers and direct addresses and doing educational campaigns to ensure the patients are going to send secure email, but they're actually going to attest to Stage 1 criteria in the period July through September, because they just don't think by July 1 they're going to have the kind of numbers that are necessary to get those Stage 2 criteria at the necessary attestation levels. So start now on Stage 2, work real hard, because remember, 2015 doesn't change at all. October 1, 2014 through September 30th, 2015, it's a one-year reporting period with all Stage 2 criteria and no delays. So in a funny way, it's a delay that's a non-delay. I mean, you could be cynical and say, a hospital can't achieve the ecosystem changes it needs by September 30th, but of course it could by October 1st. Well, we're looking at it as start now, target October 1st to have everything ready for Stage 2, and in the meantime, attest to Stage 1. So that's my advice on what to do with a delay. It buys us, in effect, 90 days, and that is a welcome relief. 2015. So there is this voluntary certification rule that ONC is currently working on that is going to do such things as clean up some aspects of the 2014 edition of certification that were messy. And some examples of this. Well, it turns out that there are a number of things that we would like to do as we're going forward to 2017 in meaningful use Stage 3 on making sure that we have lab orders electronic, start incorporating external decision support rules that might be authored by companies, third parties, or governments, start recording what devices are implanted in patients so that if there's a recall or a defect, we can easily make sure that that is repaired. But here's the fix. So it turns out the way that 2014 was written, suppose that you bought an EHR from one vendor, but hey, in your locality there was this cool health information exchange, or there was this cloud you could use that was a third-party provider. There's no way in the 2014 edition for that regional HIE or the cloud provider to certify their software, because the way the reg was written for 2014 is it said the EHR must generate the output, the transition of care summary, and transmit it. So if a HIE just provides a transmit function, sorry, not good enough. You got to generate the data too, which no HIE can do, and no third-party cloud provider generates data, it just transmits data. So 2015 edition proposal decouples this into a modular approach so that you absolutely could get an HIE or a cloud certified as an enabler for health information exchange, and therefore the modular combination of your EHR as the generator of the data plus your third-party provider as the transmitter of the data hits all of the certification criteria. You can do your reporting and attestation just fine. So that's a good change. It's a good cleanup. There is this notion in 2017 that we'll be able to do stratification of our quality measures with such things as industry and occupation codes, potentially gender identity, sexual orientation, potentially disability status, and so there's some certification rules that get us on that trajectory. And then some additions to flexibility and syndromic surveillance data transmission, offering a couple of new standards that some may find easier to implement. What about this ONC reorganization? What does it mean? ONC, for the first couple of years in the era of ARA, had a $2 billion budget. Today, it has a $60 million budget. So Karen DeSalvo has to shrink the organizational structure, and she's taking it from 17 different offices to 10 offices, and refocus on interoperability and getting what we want as the outcomes, the policy, safety, quality, and efficiency for the country, with far less operational dollars to do so. So what she's done that's really quite smart is she's assigned one person, Steve Posnack, as the person who will lead the Office of Standards and Technology and be responsible for regulation writing, as well as the testing procedures and scripts, as well as the certification processes. So sort of from end to end, you write a regulation that says a doctor will do A, and then you write a test script to make sure they do, and then you will create a certification process so that end to end it's all piloted, it's tested, it's done through an agile method, not a waterfall method where it's handed off from one office at ONC to another office at ONC. And so this will, I think, make the certification process so much better. Remember, EPIC took 320 man-years to certify its products for meaningful use stage 2. And a lot of that is because the test procedures and the scripts were just artificially difficult and convoluted. So ONC will be focusing on many fewer projects to greater depth. Its challenge is to figure out, of all the projects in process, which to discontinue, which to pass off to the private sector, which to continue guiding itself. So part of that was clarified in a recent publication from ONC describing the 10-year vision. And I will tell you, people will look at this and say, oh my, 10 years? We've been at this already for 20. Do we have to wait 10 more? What Karen has done is actually quite reasonable. And that is, if we are to measure our success by adoption and implementation, it actually takes 3 years to change society. And let me give you an example. If Karen says, the ability of a patient and a doctor to send, receive, find, and use data is important. Well, that's good, and we actually agree that pushing data from point to point, like Meaningful Use Stage 2 Direct, or pulling data is pretty valuable. But let's imagine we want to pull data. Personal example. On Monday afternoon, my father-in-law had a stroke. It turns out his records are in a primary care office, a community hospital, and an academic medical center. In order for the emergency physician to pull data from those three places, the emergency physician actually needs to go to a master patient index or a relationship locator service that tells the physician, yes, the records exist here, the patient has consented to release them, and then some kind of electronic mechanism to actually do that retrieval. Well, in the case of my father-in-law, the three different organizations are not in a common covered entity or organized healthcare arrangement or common ACO. They're three different organizations in the Commonwealth of Massachusetts. So building a statewide infrastructure that enables the discovery of where records might reside and a consent registry and all the rest actually does take years. Massachusetts has been working on it for about 2.5 years. It's now live, but it's just something you can't do overnight. Standards are not sufficient in themselves. You need policies and you need political will. Similarly, what if you have a Fitbit at home? What if you also have a Medtronic pacemaker? What if that data is sent to the EHR? Now, is a doctor going to trust your Fitbit as much as your Medtronic pacemaker? Probably provenance, understanding what device generated what data, who collected it, and how is really important to interpreting the relevance of data. So we better have data standards, especially as we're sending data from place to place, from device to doctor, that explain the provenance of the data. So got to work on that. Want to make sure there's good data integrity. And example, what if I send a summary of my care, let's say, to a doctor, and, I've secretly changed that Tylenol entry to OxyContin. Well, how does the doctor know that the data I have sent, which has a Beth Israel Deaconess stamp on it, was not some way modified along the path? And there are ways with checksums and digital signatures to make sure that the data is intact. And how do you ensure that the right patient is matched together? As an example, when we did the actual lookup of my father-in-law, his name is Harold Green, and it turns out that there are 11 Harold Greens, and they're all about his age, and Harold was a name that happened to be used in the 1930s and 40s, and how do you know you're dealing with the right one? And that's tough work too. And then how do you ensure that an emergency physician can access all of these necessary records, and there's a trust fabric that ensures that patient privacy is respected, but that the data is securely used and not transmitted inappropriately to a third party? And dealing with this whole trust fabric is both a policy and technology issue. So if Karen says 3 years and we're going to solve all of that, be able to push and pull, the ability to know whether the data was modified, the ability to trust the data, that's actually a pretty good achievement. Then you look at it 6 years, data aggregation, novel registries, quality measurement, and one approach to quality measurement might be sending questions to the data instead of having every EHR hard code numerators and denominators, as we've done in Stage 1 and Stage 2. And that's really tough because every single time quality measures change, you need new EHR software. We should probably get away from that and get to something that is more parameter-driven and query-based. And 6 years, not unreasonable. And then 10 years, the learning healthcare system. And the example you probably have heard me discuss before is in the case of my wife, diagnosed in December 2011 with stage 3A breast cancer. She's Asian, female, 50 years old, with HER2-negative, ER-positive, progesterone-positive breast cancer. Of the last 10,000 patients like her, what chemotherapeutic regimen was used? What were the side effects? What were the outcomes? What are our choices? Pretty hard to ask a question like that, and certainly impossible in the context of doing it in an order entry system in an EHR today to say, give me advice, computer, of how patients like this should be treated. So saying that's 10 years out, also very reasonable. So if that's the 10-year vision, then there's a lot of work to be done along the way to make sure the standards and technologies are ready to support it. So the StandardsInteroperability Framework, a series of projects that ONC has launched over the last couple of years, contains some pieces and parts of the sort of standards that would be useful. And as you look through this, and you see, there's the idea of capturing data from patients in structured forms. There's the idea of being able to pull data. There's the idea of being able to make patients more easily available to view, download, transmit their own data. There's things like prescription drug monitoring program, and that's a narcotics monitoring program, making sure that a doc can look at a list of all narcotics you might have been prescribed in the past. Ways of recalculating quality measures for more relevance and process and outcome measures that are hopefully going to be from end to end, more data integrity available than today. It's not up to a coder to use an obscure ICD10 code to interpret a note and then change it into structured data, and that feeds a quality measure. It's more what was done to the patient. Can I track their care, that it followed best practice? And then the data provenance, as I described. So, there's a number of these that are pretty helpful in that 10-year framework. Some you would accelerate, some you might slow down. And then a lot of work in process on things like public health and lab results and lab ordering, submission of medical data for audits, and transition of care documentation. Some of these you might just declare finished or good enough, and some that were done in the past, like data segmentation for privacy, figuring out how to do metadata on a record as to what is mental health, sexually transmitted disease, things that you might want to differentially not transmit to certain individuals in certain circumstances. So the role of ONC over the next couple of months is to look at all these projects in process, skinny it down, and maybe instead of 18 or 19 projects, there'll be 5. And So hence, if I were to summarize, if ONC feels our pain, says, here's what we're going to do, which is less, the time is going to be longer, we're going to have a greater focus, but here's ultimately where we're all going to get there in 3 years, 6 years, and 10 years, I think that actually gives us all a sense of comfort that we're not going to be running a marathon every day, that somehow the meaningful use fatigue that we're all feeling now is going to be a bit more rational. Well, let's talk about the Jason report. So if you remember the PCAST report from a couple of years ago, the President's Council of Advisors on Science and Technology, it suggested such things as, using commercial industrial grade IT and healthcare. Hey, if Google can solve search for the world, and if you've got mechanisms where all data from all EHRs suddenly becomes searchable and discoverable and uses internet-based technologies, a learning healthcare system will follow. Well, it was a very interesting report, but if you looked at its goals and trying to get there, it was a bit like saying solve today's slow commute with a flying car, or maybe a drivable plane, or whatever Google's working on next, who knows. Well, the Jason report tries to be a little bit more realistic. What it says is that, we need to look at common markup languages in healthcare that are easier than some of the standards we've used in the past. CCD was an okay start. CCDA added templates, made things a little bit easier. But FHIR and this fast healthcare interoperability resource movement, this idea that a 16-year-old who can write an app on an iPhone should be able to create a healthcare app without PhD-level domain knowledge, that's a good idea. So it's using though this is the Jason report, it uses JSON, the JavaScript notation, to transmit healthcare data in a very simple way without a lot of the overhead that has been used in some of the previous standards. So common markup language, FHIR, and JSON, good idea. Today, a lot of data transmission takes place between EHRs using things like the direct protocol for meaningful use stage 2, and that's okay. But if you wanted to write a cool iPhone app, chances are it's not going to communicate using the direct protocol with a CCDA. You'd ideally like some kind of application program interface that would allow very easy modular constructs, these new apps that would sit on top of existent monolithic EHRs and add functions that value add to the patient and doctor experience. Here's an example of one. So imagine Apple introduces HealthKit, and the HealthKit is able to interface your bathroom scale, your home blood pressure cuff, your Fitbit, or whatever. Beth Israel Deaconess happens to have an electronic health record that it self-builds, and it has an API, an application program interface, that allows seamless interaction between Apple HealthKit and our EHR. So suddenly, when we want to look at the weight change of congestive heart failure patients, when we want to look at blood pressure treatment in those on chronic blood pressure medications, we want to look at, our folks over the age of 70 exercising, their iPhone becomes the middleware to our API that allows their home care devices to go directly to our EHR in a very simple mechanism. So that API idea is reasonable. Of course, all of us are working diligently on security, and we want to make sure that only rightful individuals access the right information at the right time, and there's still continuous work to do because it's very hard to discover who is the patient, who is the doctor, what can they see, how do we record consent, what data flows under what circumstances. So the combination of security and additional metadata work recommended by the Jason report is reasonable. And then, as I've already talked about, eventually getting to the point where all the experiences that we have across our population can be leveraged so that the right care is delivered to the right patient. In effect, the computer tells us the right thing to do that is going to optimize that patient's experience per their care preferences, their genome, the disease state, etc. The Jason report is going to undergo, I think, another revision. There's going to be some hearings on it. I think there's going to be some additional input. and probably some of the recommendations will be folded into ONC's ongoing plan. So that is where we are this quarter. And, of course, Anthony, back to you. I know there's a word from our sponsor, then we open it up for Q&A, and there's always really good questions.
Very good. Well, thank you so much. I want to drop in a soccer update. Germany is beating the United States 1-0. So for all you soccer fans, now you can stay with us and not go check the score. So thank you, Dr. Lanka. We'll look forward to the Q&A. Right now we're going to hear from our sponsor, represented by Lorna Green, Senior Healthcare Informaticist with OnBase by Hyland. So, Lorna, let me pass you the baton, and the floor is yours. Thank you.
Thank you. You stole my thunder, Anthony. I was going to update the score. So
were you really?
Anyway, I was. I know these words from the sponsor can be pretty dry and boring, so I wanted to add something. But thank you, Dr. Halamka. That is always, your words always help us understand what's really going on. When I try to read what they put out, I don't always get it. So I appreciate someone like you helping us to understand it. Quickly, I just want to tell y'all about Hyland Software. OnBase is the name of our product, and we are what is called an enterprise content management company. But very basically, what we do is we can house all the data that's in your whole system that's outside of your EMR. So we kind of can be the middle place that will connect your whole healthcare enterprise. And the benefit of what we do is we have some connectors to Epic, Meditech, McKesson, Siemens, whatever your EMR is. So your clinicians can work in their main EMR, but link into our product and be able to see any type of outside records, photos, anything that is outside of the EMR can be housed into us. We have the ability to capture a number of different file formats, process them, integrate them into different ways, and then we store them. But in relation to what we were talking about today with Dr. Halamka is we also have the ability to share the data that's in our system with other systems. So we can start out, we have mobile platforms where we have mobile e-forms that you can input data, you can put the data through processes using workflow, using checklists. This gives you automation, compliance, consistency, and, of course, accountability and then reporting. And specifically what Dr. Halamka talked about, implantable device data, we would have the ability using OnBase, even using mobile forms, to input data, store it in OnBase, and make it accessible and usable when you would need it. We also have interoperability and integrations. We're an XDS source and repository. We support HL7 standards, and right now we're integrated with over 500 different applications. I think in the past, OnBase has been really thought of in the basic level as a scanning type company, but we're bigger than that. We can take all your data, no matter the source, bring it together in one view so that you have your data and make it usable. We are exclusively endorsed by the American Hospital Association for ECM. We're consistently ranked in the top tier class, and we are in the leader for the Gartner Magic Quadrant. And my name, contact information is here. Please feel free to contact me for anything I can help you with. Here's our OnBase website and Facebook site, and then just an article that we just recently put out this week about how our checklist case management solution has helped one of our customers win an award. So now it's back to you for questions and answers. Thank y'all.
Very good. Thank you, Lorna. Please keep us updated to the score, Lorna, and we would appreciate that during the Q&A. So, Dr. Halamka, I had one CIO contact emailing me recently saying he was under a lot of pressure from his CEO to meet stage 2. And he was trying to, I guess, convey the point of the difficulties involved and whatnot. I would imagine there's other situations out there like that. Do you have any advice on how the top-level IT folks can communicate some of the nuances of what you've described today and the issues going on that maybe take the CIO out of the hot seat a little bit?
Sure. I mean, two pieces of advice. Generally, the CEO wants stage 2 milestones to be achieved because of the stimulus dollars that are available for doing so, and the fact that this particular period of time, 2014, was going to be used as the benchmark for the 2016 penalty phase. So you could miss 2014 and not only lose maybe hundreds of thousands to millions of stimulus dollars, but worse, your Medicare rates might go down 2% in 2016. It's a lot of pressure to get this done. So with the NPRM, this Notice of Proposed Rulemaking, we hope gets approved very soon. You're able to achieve what you need to get stimulus and to defer any penalty by doing the Stage 1 meaningful use attestation for 2014. So in effect, you've met the CEO's goals while you're busily planning for getting to the 2015 meaningful use Stage 2 criteria. But at the same time, pretty important to communicate to the CEO that no matter how much the CIO does, that doesn't really help you with the trading partners in the community getting their act together. And so what I see from many CIOs is they say, this is a task list. Everything I can control is checked and ticked and tied, and I can only tell my CEO, I have no control over what the private doctors do 25 miles away and their EHR's ability to receive our transmissions. That's all. Get your money, do your best.
Okay, great. What if in the race for MU2, processes used for MU1 were discontinued and we can't go back and attest to MU1 again? What are the options used to blend? What are the options of blending MU1 and 2? Do you understand that question?
I do. So remember that, so let's be clear. When I say MU1, what I really mean is the modern, MU1 has actually been refined over time. So you look at the 2014 criteria for MU1, so they are a little different than the 2011 ones. But most importantly, the quality measures, which is really what people are no longer computing, are the 2014 quality measures. You're not doing the 2011 quality measures. So I actually think what you'll find, because really the MU criteria all still need to be done in MU2 that you were doing in MU1, you'll find as long as the quality measures are the 2014 quality measures and you're using the updated MU1 criteria, I'm pretty sure every EHR in America can actually support them.
Very good. We were just admonished by a viewer who was taping the game and said we were spoiling it for when he goes to watch it. So we will not give any more. We will not give any more scoring updates. All right, next question. This is to you. First, thanks for all you do to help the industry become more digital and data-driven for all these years. It seems to me that there's something wrong in an environment if it takes vendors hundreds of man-years to modify its products to reach MU2 requirements. Lately, I've been opining in various forums that we should either cancel or significantly downscope MU2 and 3 and allow more free market innovation to evolve from the EMR investments under MU1. Am I crazy?
So you would be completely sane. There are two issues here. MU2 just had a set of test procedures that were artificially hard. And I went through the exact same certification process for my home-built system that Epic went through. I didn't have 320 man-years. I had 5 guys and a bunch of coffee. And what do we do? Literally, the tester got on the line and said, okay, today we're going to test your quality measures. We need to do 528 different demonstrations. What? Oh, yeah, not only the 19 measures, but it's 19 measures stratified in 6 different ways for 20 different patients, and we're going to change this, that. And it's like, do you really need to do 528 demonstrations to prove that you can calculate a numerator and denominator? Probably not.
Right.
And I don't really blame NIST for this. NIST, as an organization, does National Institute of Standards and Technology, does all kinds of script writing. And all they're doing is trying to dutifully make sure that for whatever criteria they're given, that the test procedures test those criteria. And this is what I was getting at with Steve Posnack, now running the Office of Standards and Technology. Instead of saying, oh, here's a bunch of criteria, hand off to somebody else, go develop test scripts, hand off to somebody else, go develop a certification program, it's one totally coordinated program. And so 528 different processes? Probably not. Do 3. So MU2, artificially too hard, didn't need to be that bad. But as we get on to the next stage of meaningful use stage 3, I completely concur with the person who asked the question that we need to reflect on policy outcomes without being overly prescriptive as to how you achieve them. I'll give you a couple of quick examples. I implemented Google Glass in the emergency department at Beth Israel Deaconess so that doctors can see patient data in real time while examining the patient and touching the patient instead of staring at their keyboard. We've had a couple of instances of lives saved because the data and telemetry is available in the field of view of the doctor. Well, what if the policy goal said, use technology to improve patient satisfaction in the emergency department? Now, whether it's Google Glass or whether it's that you use iPads or wireless or RFID, totally up to you. I would much rather see goals like reduce readmissions and improve the patient experience, and the choice of technology is then given to the provider or to the hospital. That would be, to me, a next logical phase.
Okay. What do you think of the current marketplace for consumers in terms of mHealth and how standards will help enable care coordination for provider EHRs, HIEs, and home health devices?
Fabulous question. So today I have a Y-Thing scale. My Y-Thing scale uses an XML or a JSON format to submit my weight data every day to Microsoft Health Vault or Twitter, though tweeting my weight would be strange. And yet there is no easy way at the moment, though my Fitbit can talk to my scale, can talk to my blood pressure cuff, can talk to my Twitter account, to get that data into an EHR. And so you look at middleware solutions like what Apple is trying to do with HealthKit, the idea that you will have an appliance running on your phone that gathers data, whether it's Samsung or Apple or whatever. It will gather data from these multiple disparate devices and then build a trust relationship to an EHR where the data then can be transmitted and used. I think that's a really good idea. So we definitely have a hard time today of interfacing EHRs to every device in your home. Having a piece of middleware that helps will certainly accelerate that process. But Apple HealthKit at the moment is very, very early. There aren't actually standards baked into it, like what is a blood pressure or normalizing using a controlled vocabulary, SNOMED, LOINC, or other things, the data that comes into it. So I'll hope over the next couple of months as that product becomes more commercial ready, that it does do some of these functions that are going to be absolutely foundational to getting data from the device into the EHR in a way that a physician can act on.
Very good. We talked about some of the movements in the dates for the programs, Stage 2 and whatnot. It sounds like from what you've said, dates may change, things may change, but this stuff's not going away, Stage 2, Stage 3, and you really don't get to opt out. So if you're going to be late or you're not going to make the dates, that's one thing, but you still have to do all this stuff. Is that correct?
When I speak with folks at ONC, in fact, and folks in federal government in general, what they'll say are, Congress told us we must do this as part of ARA High-Tech. Regulations tell us we must do that. The levers that we have to completely eliminate the program are few. Mm-hmm. And so what you're going to see, as you say, is maybe change in scope, maybe a penalty is going to be removed, or maybe a delay is going to be allowed. So I think the trajectory that we're going to have some criteria that are going to require that the vendors and the providers keep marching forward is true. But you do have an Office of National Coordinator now that's really listening, gathering lots of input, and recognizing we try to do too much too fast, haste will make waste. So that's why I feel pretty optimistic that, yes, we'll have work to do, but the pace of that work will be achievable.
Right, right. And your thoughts, you remember a little while ago we had, and we've seen other instances where Intermountain said they were opting out. They were putting in, I believe, some Cerner in their organization, and a couple of hospitals, they would really have to jam it in to get it ready in time. I'm sure a lot of other folks are making those decisions. There's a patient safety issues, there's ROI issues, penalties, all these kinds of things. Any thoughts around making those kinds of decisions?
Right. So when you look at risks, right, everything these days is a question of risk and mitigation of risks. What if you just don't do the HIPAA omnibus rule? Well, $1.5 million fines, wall of shame, reputation loss, could be really devastating for your organization if you became known as the organization that ignored patient privacy. Probably that's not an option. What about ICD-10? Okay, fine. Delayed until October 1st, 2015, but let's say that it does keep going forward on that date, as CMS has indicated to us. Unless you're ICD-10 ready, your entire revenue cycle will stop. Oh, better do that one.
Right.
The Affordable Care Act. Well, if you're an ACO and you're in global capitated risk contracts, putting in care management systems and all the necessary data warehouses and business intelligence to keep patients well could be your revenue cycle, half your revenue cycle, some big number at risk. Meaningful use, $2 million. Oh, well, God, that's not so bad.
Yeah.
So what I've seen in many large healthcare systems is that when they evaluate the risks, meaningful use is the least risky issue, and therefore, if too much is on the plate, got to somehow skinny down the plate. So I'm seeing one of the things I've predicted is that we're going to see a number of doctors and hospitals opt out of the program unless there is the scaling back of the amount of work and the time frame, which is what ONC is trying to do.
Yeah, great points. And yeah, it's important for people to step back and look at that to-do list and say, okay, we can change the order of that to-do list and prioritize it based on some of the numbers you mentioned. So I think that's great. Any more you want to talk about, any more advice really quickly on ICD-10? I know you had talked about sort of not losing momentum and not having to sort of, stop the train and then all the energy it takes to completely restart it. Can you just describe that a little more, how you're handling that to get the most out of that investment and your advice for others on that?
Well, absolutely. And so just like the person who asked the question about sanity, one of the things I have tried to do with NCVHS and HHS is question the sanity of the entire ICD-10 idea. Not that anyone's listened to me, but, Anthony, I run a farm in Sherburne, Massachusetts, and being able to code my chicken injury versus my guinea fowl injury doesn't precisely help the, United States with quality, efficiency, and safety. Come on, guys. This is not actually a positive ROI for anybody, an improvement of quality, or in any way going to make the patient experience positive. So let's just stop it. The whole ICD-10 idea should be replaced with we're all going to just document better and use SNOMED codes, and behind the scenes, computers will be able to create structured data out of unstructured data. Everyone thinks, come on, that's too much, too fast, can't go there. So if we can't blow up the whole ICD-10 idea, then you have to leverage the investments that you've made, which is, of course, the prudent thing that I'm doing. Massachusetts, as a community, brought its payers and providers together and said, although we know October 1, 2014 isn't go live, we're going to pretend it is anyway. And what I mean by that is our end-to-end transactional testing from providers to payers, ensuring that every revenue cycle can proceed intact, is in process now. We will, by this summer, have done 100% of our ICD-10 fully integrated testing. We'll be ready October 1, 2014. Now, it would be illegal for us to turn on the functionality live because CMS doesn't recognize that ICD-10 codes are valid, in fact, can't, by the Sustainable Growth Rate Bill until October 1, 2015, but we will be ready. So when it comes to next fall, we'll do a little regression testing, but in effect, it'll be flipping a switch and things will be pretty much ready to go. That's, wrap it up in a bow and park it on the shelf in a completed state, not in a half-done state.
All right, one more question came in from a provider, so I want to get it in. Do you believe the NFERM will be made law essentially as it is, or are the comments likely to cause material changes to the final law?
Yeah, what I hope. So first, it's going to go through, right? Everyone knows there's no way for hospitals and eligible professionals, right? 8 hospitals have attested to meaningful use stage 2, and here it is, basically July. 491 providers have attested to meaningful use stage 2 out of 500,000. You got to put it in place. What I hope happens is, not only is there going to be this idea of being able to use stage 1 with the 2014 quality measures in the July-September period for hospitals, but you won't have a year-long attestation in 2015. You'll have a 90-day attestation in 2015. Because really, if you look at everything that's going on with healthcare information exchange, a 90-day delay doesn't buy you everything you need to get an ecosystem changed. But having the capacity to say, actually, if I had until next July before the reporting period began, I could absolutely get everything done. So combination of give me a better set of criteria in 2014 and a 90-day attestation period in 2015, not a full year, so I can really get it done. That's what I hope.
All right, let me sneak one more in here. Do you really believe that we'll be able to turn unstructured to structured data? Works great in tests, but live success across sites is questionable.
Yeah, so I have been spending a lot of time in the last year working with a whole variety of startup companies and some established companies on doing structured data or metadata capture from unstructured data. And as the questioner says, it's not perfect. I mean, suppose you get precision and recall in the mid-90% someplace, So, I mean, if there's a crazy sentence like, the patient whose mother had breast cancer is doing fine. Doctors use inappropriate sentence structure and grammar and terminology all the time, so it's tough. But what you sort of wonder is the slop that we're going to get in ICD10 anyway isn't perfect. I mean, right? 170,000 codes, and, we're going to get the bird species right. Probably the idea that for some purposes that using natural language processing is good enough. And let me give you an example. I have to run the care management program on behalf of hundreds of thousands of patients. I want to enroll diabetics in care management. What if they don't have diabetes in their problem list? Well, what if natural language processes identify in full text notes the word insulin, the word peripheral neuropathy, the word retinopathy, and the note hemoglobin A1C Q month? Well, that would probably be a good indicator they're a diabetic patient. And so fine, I enroll them in the program, only to define, they're actually a patient with polycystic ovarian disease and artificially inflated sugars, not diabetes. Okay, fine. Then I disenroll them in the care management program. No harm, no foul. It's better for me to identify those who are likely to benefit than to occasionally be incorrect. So pick the use case for which NLP gives you a positive result.
Very good. Well, I think that's where we went about 5 minutes long, but we had great questions, so that's where we'll leave it today. As I mentioned, all our attendees will receive an email when our archive is ready and a separate registration is required. If you've asked us to, we'll communicate to Chime your attendance for your CHCIO credits. If you have not, don't forget to report that yourself. I want to thank our sponsor again, Lorna Green and On Base by Hyland. Of course, I want to thank Dr. Halamka for doing this event with us quarterly. It's always a lot of fun. Questions, comments, email me, and you can go to our website to view the last 12 months of archives and the upcoming events. So with that, again, I want to thank our speakers and our attendees. Everybody, have a wonderful day.
Thank you.